Mayom's organizing and scientific committee for the invitation. Thank you, Dr. Muhammad, and thank you, Dr. Abdullah. In quick that I would like to share you this is a case of epiretinal membranes. Usually we do our epiretinal membranes, simply that you can peel it with not that difficulties. All of this is that that epiretinal membranes is either primary or could be secondary, and one of these causes is inflammations inside the eye. It has been classified in many types, but with the advantage of the OCT, we have really new types of classification based on as with the visual acuity and correlated with. So I will share with you this case, 27-year-old female with idiopathic type of intermediate uveitis that had complicated course during her management, lost her other eye, left eye, of retinal detachment and complicated surgery. She's presented with visual acuity of 2200 and pressure was within normal with glaucoma medications. This patient is having these types of epiretinal membranes, which is unusual to have it like that. Some of them they're fibrosed and being over the retina surface and incorporated in the intraretinal types. So being subjected to vitrectomy, and as you see, I'm sharing with you this type of video, so enhanced as usual. Getting in the triamcinolone assisted vitrectomy, then I used brilliant blue to stain the membranes itself, and then starting the game with this membrane. It's not normal membrane that as you see. So starting with picket with little bit, some come downs without. All of the fovea is getting with me. I'm afraid to get all over, large macular hole with this peeling. So starting in some of these epiretinal membranes being intraretinal rather than just to be in the surface of the retina. So starting with this, playing around in circumferential preference, like as you see here, getting in. And my heart was beating a lot at this time. So what I have to read, this is the only eye with already ischemic retina from the previous attacks of the intermediate uveitis and vasculitis. Getting in. See it? Now starting here, I couldn't make it more. And you see this large, membranes, fibrous in the surface and even though in the inner layers. So now here I'm stuck. What I have to do, starting to use my scissors to get in, but I'm afraid that to penetrate. All of the fovea is especially spongy and seem like an oxidative detachment of the macula. So now I'm getting in the place, so I couldn't do more. Now I'm getting the chandelier. This is the chandelier that I use. It's flexible, it's helpful, it's not that stiff as you do that in the others of Alcons. So we get it in, and I'm starting to use the pipe manual. When getting in, so it's easy getting out. Now the second step, after that, removing this membrane. So getting out, now starting to go for the ILM. And was able to at least to get some of this membrane to prevent recurrency. So with this, so the ARM is removal is risk factors for recurrency. ILM is helpful to decrease this recurrency, but also even though the outcome visually is showed that no difference between both sides. So in conclusion of this case, see this is the OCT is better. Now I gave the patient some sort of Ozurdex to get, can I get just only the conclusion if you don't mind? So preoperative counseling is important in this patient because the risk and benefits must be clearly defined. Age, work status, fellow eye status, activities and symptoms has to be considered in all this patient management, customized for every patient, and using pre-op, protocols with immunosuppressive medication, steroids. All of this important, especially in inflammatory types. OCT assessment is helpful to know where it is, but certain cases like this is difficult to know how. Early intervention is important to prevent such case like that, and peeling of ILM is important, in my opinion, in these cases, rather than to leave it. Thank you for your attention, and I would like to invite all of you to our meetings in King Khalid Eye Specialist Hospital. Will be in December, mid of December, and even though our Saudi Retina Symposium on February 2026. Thank you for your attention.
Thank you, Dr. Hassan, for this nice talk. Dr. Mohammed Maghazi, do you have a comment about the epiretinal membrane?
Yes, I'd like to ask you, at that case, what was the visual acuity preoperatively?
It was 2200.
And did it improve actually? Because some of those cases with, history of uveitis, they usually don't show any improvement with the...
This surgery, this is a single-eye patient, first of all. Second things, this patient is really now affected by these membranes and even this morphopsia of the hair regions. And in addition to that, if you leave such membrane and getting any attacks with, recurrency, it might be getting worse. So for that reason, I get in to remove all of this vitreous and this membranes, because removal of vitreous in this patient as well is traumatic. Yeah. In addition to removal of membranes.
Also, the ILM peeling in those patients is rather challenging because some of those patients have very thin retinas in the macula.
Yes, it is not normal ILM
yes.
hair.
Would you insist in ILM peeling in those cases? I mean, we know that there is a higher risk of recurrence if you leave them, but I have seen cases, uveitic, post-uveitic, and after removal of the ILM, they actually develop a macular hole. And at that stage, it will be difficult to manage.
Yeah, but being attentive to this patient is very complaining of her, poor quality of visions, and even though that this membrane is a thick fibrous, it's not like, regular membrane that you think. So I tended to remove it, and then I don't like to get back in the eye. Yeah. So the only thing that in my face is that to remove this ILM, although it is fragile, as you see, it is really fragmented. Yeah. But even though after that, the OCT was in that, because I would like to give her the injections, the Ozurdex, the anti-VEGF, to be effective with the, stiff ILM, it will not work that enough.
Thank you, Dr. Hassan. Our next speaker is